Hello everyone, this is Shad Reyes and this is SIF 2021. With me is Dr. Michael Rinaldi. He is Director of Structural Heart at Sanger Heart and Vascular. Dr. Rinaldi, thanks for being with us.
My pleasure, and thanks for asking me.
It's so pleasure to meet you, and you're coming from a renowned institution doing a high volume structural. I would like to start first with the impact of COVID on your volume and how you treated these patients during the pandemic.
Yeah. So we, like most institutions, struggled through COVID, but we had a plan in place, and that plan was to, shut everything down and go completely virtual at first, and then that sort of loosened up as the sort of cadence of the pandemic sorted out. So there was a couple months where we did very little elective work. But one of the first things we did was to triage our structural procedures, because I think, chronic stable angina, people don't generally die of chronic stable angina. But aortic stenosis and mitral insufficiency, people die from if they put that off too long. So we I think, did the same thing many institutions did without talking to those other institutions. It sort of, I think, was an intuitive thing that we all figured out on the fly, which is we created sort of risk and acuity buckets. And so there are patients who had to keep going now, patients who probably could wait but probably shouldn't, and those who absolutely could wait. And we spent the first 2 weeks of that pandemic calling all of our patients and trying to figure it out and triage them.
How they're feeling, symptoms.
Yeah, exactly. Yeah. And explain to them what the situation was. And it's amazing how many patients were very understanding of the situation, and that speaks to the average person's humanity, which is wonderful. So we actually never shut down our TAVR program or our CLIP program. Probably volumes at first dropped by a good 50 to 30%, but by the end of the pandemic year, we had only dropped about 20% in our total volume. So we were able to get those critical patients through. One of the things we've also noticed is that patients are presenting later. So they're not seeing their doctors. Because they're not seeing their doctors, they're not telling them about issues.
Exactly.
And I think while virtual care is an important sort of stopgap measure through the pandemic, and I believe has a huge role in medicine going forward, but it's not the same as in-person medicine. How do you talk to somebody about a murmur you heard on exam if you didn't examine them? And when you heard that murmur, oh, maybe I was having some shortness of breath. How do you include their family member, which is classic? The patient says they're having no symptoms, and the spouse is sitting next to them shaking their head saying, no, tell the truth. And so I think that there have been a lot of challenges. I don't think anybody did it right at the beginning, but we've learned and iterated going along.
Absolutely.
And we made it through. And our hospital, like many, was inundated even through just post the holidays. It's finally starting to ease up with vaccination, and I guess maybe just post-holiday, contacts.
Absolutely.
And I'm so hopeful for the future. Things are starting to feel like they're getting back to normal.
That's great to hear. I mean, your protocol, I never heard anybody did that kind of shutdown program. I've been asking other operator about the same thing. Let's shift gear to structural heart. This is your passion. This is what you do every day. Let's talk about mitral valve. What is currently in the pipeline and what's new?
Yeah. So we have always been big enthusiasts of transcatheter mitral valve therapy, particularly through MitraClip. We were very early in the MitraClip experience as one of the first 10 centers to ever do the procedure. And so we now have 15 years of experience under our belt. So we're an experienced MitraClip center. And I think one of the things that we did was, in addition to our standard TAVR conference, which is a wonderful thing, we sort of created a separate mitral conference and really involved our mitral surgeons who've always been supportive of transcatheter therapies, but really just broadened it. So I think creating a parallel process in mitral to what has worked in TAVR for many institutions, I think, is a recipe for success. Beyond that, we're excited about the new indications for transcatheter edge-to-edge therapy on the heels of COAPT and understanding that there is a Mitra France out there to sort of help direct who is going to benefit and who's not going to benefit. MitraClip therapy is now a Class 2A recommendation for high-risk primary MR, and also any risk, secondary MR, in appropriate co-op-like patients who've been optimally medically managed. So, this is important and provides the backup behind what has been a practice, sort of standard for us. But I think it also gives those people in our practice who maybe quietly weren't as much of believers. I think now we have FDA approval, CMS reimbursement, and ACC/HA all in concordance. So I think that's a wonderful thing.
So you came a long way from
It's been a
trial.
It's been a journey. Yeah. So one of the things that we're working on that we're excited about is, when you look at MitraClip, people are quoted certain success rates. What's the likelihood of getting 2+ MR? In the EXPAND registry, it was like 95% plus 2+ or less, and 80% 1+ or less, which is way better than the old Everest days. And those are in high volume, high experience programs. But I think it is probably reflective of what you can do with good imaging support and good interaction with your imagers. But not every valve is the same, and we've never really had a way of quantifying that. So Abbott put together, through sort of some thought leader guidance, which I'm happy to have been part of, sort of a way of looking at the complexity of valves on an A through D scale, a complexity tool management. So A is the easiest. There, would be the slam dunks of MitraClip, and D is like really hard, unstable patients, very complex anatomy, massive flails and wide flails and things like that. And so, but that's never been validated, and there's really been very little work to look at other than some early looking in the EXPAND G3 registry. So we have actually looked at our first 100 G3 cases. Now we're about to add another nearly 100 G4 cases, and looking at how we can validate that. Does this sort of thought leader generated stratification of complexity, what does it really mean? And does it correlate to reality? So we actually submitted that as an abstract to ACC, and it was accepted, so we'll be presenting that data. So we're excited about that.
That's your own data.
That's our own data, so look out for that at ACC.
Perfect.
Excited about G4. G4 is an amazing technology. The wide clips are now 90% of what I and most other people use. And there are roles for more classic short-armed narrow clips, but G4 is an excellent technology, and I think the independent grippers are amazing. I was lucky to be able to use Pascal early in its iteration, and I think that trial is moving along and will be a welcome addition to edge technology. It has some particular potential advantages, including sort of lengthening it instead of inverting it to get it out of the ventricle, and a spacer that may have an impact on gradients. I'm not entirely sure where that will fit as a competitor to MitraClip, which is, I think the standard of care right now. But competition is welcome, and having more than one choice is always a good thing for us as clinicians
for
and for patients
and for the community.
The other things that I think are interesting that are coming are transcatheter mitral valve replacement. So, the first device that I think people have the most experience with is Tendyne, and we've done some of those cases, and it's a very exciting technology with no MR, fairly straightforward to deploy. Transapical gets a bad name from the TAVR world, but because of that apical pad, it's really part of the problem with Transapical is closure, and the pad that comes with Tendyne, because Tendyne is secured with a cord that hooks it up to the apex of the ventricle, that seals the apex, so it makes it a much safer and I think better procedure.
It is combined with the surgeon, right?
It is combined with the surgeon. It's a surgeon. It's like TAVR. It's a two-person procedure, and you really need two people because you need somebody positioning the device and somebody holding the tether. It's really, I think, a two-person procedure. So that's exciting technology. But there are other transseptal devices on the way. Edwards M3, Abbott's next device, which is Sophia, which we will be implanting as one of 6 centers. We're excited about that. There's a very interesting technology, 4C's Alt valve, that we've actually put in.
The globe.
It's really crazy technology, but crazy enough that it just might work. So one of the problems with TMVR is LV outflow tract obstruction, and so one way to get around that is to have nothing in the LV. So the Alta valve has a superannular mitral valve that is contained within a nitinol frame that is sort of like a watchman for the left atrium. It's a little bit oversized for the atrium, and that holds it into place by downward force. And so one of the advantages is that there's no worries about LV outflow tract obstruction. The other potential advantage is pretty easy path to transeptal delivery, and so they've now done some transeptal work. So interesting, different take on it. It's a lot of people trying to figure it out and using, technology overcomes, and the engineers, thank God they exist, because everything I do is dependent on stuff they innovated.
Absolutely.
There's Intrepid's, the Medtronic Intrepid device, which is also working its way towards transeptal. There's the entire field of tricuspid. We can get there in a minute. But the other interesting technology that we'll be involved with, that others have been involved with, is Neocords, right? So everybody thinks of transcatheter therapies as either clip or replacement, but there are other technologies. So one would be for a posterior leaflet flail is put a cord in. A cord would not burn any bridges for surgical repair in the future. It would not even burn any bridges for a clip. So there's a technology, a company called CardioMech, which has a transeptally delivered device, but there are other companies. But we'll be doing a first in man, hopefully in the next few months, as a transeptally delivered Neocord. So that's exciting.
So this is, you hook up with the flail's leaflet and you hook it up to the
That's
apex.
right. It's almost got like half of a mitral clip. You grab the leaflet, then you secure with basically like a little puncture, a hook. Grab the posterior leaflet, and then you can let go and then deliver it down to the ventricle,
to the wall.
and then you have the ability to tension it or adjust it just right, so you don't you don't have any more flail, but you also don't over tether it like in secondary MR. So it should be very safe, and it could be a very interesting addition to primary MR. And then there are all the annular technologies, which I think have been a challenge because they're so difficult to get in, but I think millipede is exciting, and we'll see where that one goes for secondary MR. So, TAVR is like valve replacement. Mitral is such a complex, and really it's a bunch, it's the phenotypic manifestation of a bunch of different disease states between primary, classic Carpentier 3A, secondary from LV dysfunction, and atrial mechanical Carpentier 1. They're all very different mechanisms, but act the same in a similar way. So no surprise, we need a whole bag of tricks and tools. What will survive, what will really depend on outcomes and volumes. Even if something works, if we don't find adequate cadence to use it, we won't get good at it, and that's really important that we get good at it.
And durability too, maybe.
Absolutely. Durability is important. Other questions about, everybody'd love to just do a replacement, but one of the hard parts about replacement is you probably need anticoagulation therapy, and a lot of these patients can't take anticoagulation therapy. What happens if they're subtherapeutic? There are so many interesting questions that need to be answered.
Absolutely. Well, that's a great overview of what's up and coming and what you are doing as well, Dr. Rinaldi. I really appreciate your time. Please watch this video on YouTube channel for SIF. This is Shadi Reyes from SIF 2021.
Thanks
so much, Michael.
Thank you.